Yes, we have a quorum. So, good afternoon. Today is February the 2nd, 2022, and it is 1 o'clock exactly. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Texas Health Strategic Planting Committee. As a reminder, some of our committee members are also participating by video conference. So the staff will be managing the video and audio feeds of all the participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. So Yesenia or Yvonne, did anyone register to make comments at the board meeting today?
No, Madam Chair, no one registered either online or in person to make public comment today.
Okay, thank you. So we will move forward and proceed to the committee agenda. So, number 1, receive and discuss an update on equity-focused systems planning, including findings of the Safety Net Community Health Needs Assessment, Capabilities Assessment, and Clinical Gap Analysis. So, I'm not sure who's going to start this meeting.
Thank you, Dr. Brunson. This is Monica Crowley, Central Health Chief Strategy and Planning Officer and Senior Counsel, and Dr. Abhi Sharma and Danielle Srinivasan from Guidehouse will be presenting today, and Central Health staff will be available to help respond to questions as well.
Thank you.
Perfect. Thanks, Monica. And good afternoon, everybody. First of all, I wanted to thank everybody for making time. I know it's difficult to get together in these times of COVID, but I really appreciate you getting together to pay attention to what we are going to present today. And as you know, Guidehouse was hired by Central Health to develop a strategic systems of care plan that would inform the strategy for Central Health from this year for the next 5 years. And what we wanted to do today was a couple of things. And if you go to the next slide, we want to provide a brief update on progress and achievements, but we want to spend the majority of our time today sharing findings from 2 key assessments. The first assessment was the CHNA, or the Community Health Needs Assessment. And the second assessment was more internal to Central Health, which was looking at Central Health's capabilities and assets to meet the needs of the community, and then to identify gaps in capabilities where we think Central Health needs to focus in order to meet the unmet needs that were identified through the CHNA. Please stop us if you have any questions or comments. We want this to be collaborative. And this is a pivotal moment because we plan to use the strategic plan to embark on a multi-year planning process, which would enable Central Health to meet some of the unmet needs in the community, but also to refine some of the capabilities that are core to providing health to the safety net population. So again, we want this to be collaborative. Please jump in, ask questions, comments are appreciated. But again, let's make sure that
briefly, if you'll stand by, please, just a moment.
While I'm restarting, can I just join his computer? So rather than him stopping, I'll restart it and I'll join from here for a second. That I'm physically, okay.
That's fine.
Sorry.
If you'll stand by, we need to restart one of the laptops so that we're on screen. Thank you.
Hello? Manager Valadez, we can't conduct business until Moran comes back.
Yes,
Yes,
she's
she's
restarting her
computer.
computer. Yes,
Yes.
so you
joined
at the perfect time.
So do you want me to wait or?
Yes, just please stand by for a moment.
Okay, that's fine. Just checking.
Mr. Duncan, could you update me on the members of the Strategic Planning Committee, please?
Yes, sir. Let me pull that up right quick. I have got that open right over here. The strategic planning membership, it's taking a minute to open, sorry. Strategic planning membership, obviously the chair is Dr. Brinson, Sherry Greenberg, Manager Valadez, yourself, and Manager Musaitov. And the in-person quorum, if we need a person to make quorum, the board chair is automatically a member per the bylaws. So Chair Bell is our third member in person at the location.
Okay, so how many members constitute a quorum for the strategic planning meeting?
3.
Okay.
And right now we technically have 5. We have 3 in person and yourself and Manager Valadez.
Okay, so it has to be 3 in.
Correct.
Okay, all right.
Which we do have.
Yes, thank you. So we are back, and so you can continue if you would.
Madam Chair?
Yes. Yes. Yeah. Ms. Valadez.
Thank you. Thank you. I have a question. He said for us to ask questions as we went along. I want to know whether or not you want us to do that. And if so, then I'd like to ask some questions. But before we get too far into this, and at least maybe for the edification of the board of past actions.
So we do have to worry a little bit about time with this meeting. It's going to be probably a long meeting. And so if we can hold our questions perhaps to short statements, short questions, that will be fine if we do it during the meeting. Otherwise, if it gets too onerous, we'll pause it and just have questions in between the gap part and this first part. Yes, Ms. Manager Valadez.
So I personally would appreciate it if you would tell us, Chair, when it would be appropriate for us to ask a quick question or not. And that's all you need to say is, okay, if anybody has any questions, ask now, because you're the one that's controlling the time. And so I think that would be a best and most appropriate thing to do.
Okay, so Manager Valadez, you have a question?
Yes, I know that in the past, we have had similar analysis made regarding it was back then we talked about it in terms of integrated delivery system. We had talked about it as CUC updates, blah, 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 starting in 2013. And I think it was Navigant that worked with Central Health at the time. I was not on the board, but I came and listened to the meetings. So I'd like to know where the results are for all that work and millions of dollars that has been spent on that. And I'd be curious to know whether or not those results were used as a platform to update the community needs assessments and look to see where we're what gaps have been identified during the interim, since Guidehouse did buy out I'm assuming, or absorb Navigant. They would have all that information in-house.
Yes, Mr. Duncan, can you answer that question, or Mr. Giesman?
Actually, Manager
Because
Valdez,
most board members here were not on the board at the time.
Sure. Manager Valdez, I'm not able to answer your question today in part because I think we would need its own standalone agenda item to go back and look at what happened starting in 2012. This is about going forward with the data that we have today and what the next pathway looks like. So as I sit here today, I'm not able to answer your question, and we'll have to, I know that you and I have had conversations in the past since I've come on board about the integrated delivery system, and we presented numerous presentations to board committees and the board in the past on building out the healthcare delivery system, and so it would, your question does not lend itself to a short, concise answer.
No, I didn't.
Multiple that we've had before in the past.
I didn't think that you'd be able to answer because you weren't here at the time, but I believe that for the interim before now in our next meeting, I would personally want to know from Guidehouse where that information is and whether or not it has been used as a basis to update the community needs assessment and where we're going type questions. That's all I wanted to present to them while we have somebody here from them. That's, and I appreciate that. And I'll put this stuff in writing and send it to you. Thank you.
Excellent, excellent, thank you. And so we'd like to go ahead and start, and so if the Guidehouse is ready, let's begin.
Yep, we are. So like I mentioned, what we want to do today is focus on the key findings from the Community Health Needs Assessment, which was external facing, and then also focus on the results of our capability assessment, which was internal facing. And if you go to the next slide, this slide is extremely important for us to spend time on. Now, this talks about what we've done, what has come out of it, and what do we do next. Now, like I mentioned, we focused our time on assessments. So we conducted the Community Health Needs Assessment. We looked at internal capabilities and clinical gaps from Central Health's point of view. And we used voice of customer to collate the results of our quantitative analysis with what we were hearing from patients in the community, from community stakeholders, from community organizations. Now, based on these three efforts, we delivered or we ascertained some key outputs. Now, the first thing that we identified were gaps in clinical care delivery. Now, we go into the details in subsequent slides, but I want to level set on what the nomenclature for these gaps essentially means. Now, for each gap, we have labeled a gap significant, moderate, or minimal. Now, a significant gap means that given Central Health's current capabilities, less than 50% of community needs are being met. Moderate means that 50 to 70% of community needs are being met, and minimal gaps means that more than 70% of community needs are being met. Now, we've done these assessments for many systems across the country. I personally have done this assessment for Harris Health, for UT Brownsville. And what we know is if a safety net organization gets to a point where they are meeting 70% of community needs, that is really good for us to keep as a high benchmark. The second set of results were internal facing. So we looked at capabilities and assets of Central Health and used our experience with other systems to talk about the maturity of those capabilities. So essentially, how good are those capabilities from the point of view of meeting community needs? And based on that, we categorize capabilities as robust, adequate, or limited. Now, when we talk about robust capabilities, it means that those capabilities are equivalent to best practices for safety net systems. If we think about adequate, it means that they are not best practices but are enough to meet the foundational needs of the community. And if they are limited, it means that they are not even at a point where they can meet community needs. And we need to focus on maturing and refining these capabilities so that we build the foundation to think about how we can leverage these capabilities to meet community needs. So again, to take a pause here, we conducted assessments, and then that resulted in the products that you see under the results section. Now, the question here would be, okay, so what? Now, the so what here is based on our results of where needs are the most and what capabilities can be used to meet those needs. The next question that we need to answer is, for areas that are deficient, where we don't have capabilities, what is our next step? Do we go ahead and outright own those capabilities? An example could be employing a primary care practice. Do we manage those capabilities, which is we don't own those capabilities, but we operate those capabilities. Telehealth could be one of those examples. And then the third could be, okay, we don't want to own that because there's a lot of risk. We don't want to manage it because it's capital intensive. Do we really think about sending out a contract, an RFP, and contracting with providers to make sure that those needs are met? Now, what we will follow up with after this meeting is a strategic plan which would enumerate all of these things in details. Now, the difference there would be, it would be more forward-looking. So based on our assessments and results, we want to think about the areas that we want to focus on, and that would be the focus of that strategic plan. So for primary care, what should the focus be? For specialty care, what should the focus be? For IT and other supporting capabilities, what should our focus areas be? So again, this is extremely important for us to understand. We conducted assessments based on quantitative data. We collated that with what we were hearing in the community so that we had a very well-rounded understanding of what the current situation was. That yielded results. Those results are pointing us to key decisions. Those decisions will be focused on whether we own capabilities, manage capabilities, or contract for those capabilities. And the formalization of these next steps would be through the strategic plan. The next slide, please. And I'll pass it to Danielle to take us through this section. Danielle.
Good afternoon, everybody, and thank you again for your time. So on slide 3, what we want to do here is just summarize what have we been charged with today. So what are our objectives that we were trying to achieve through this, very critical scope of work. So number 1 was the voice of the community work, which was a community engagement strategy to really understand the perspectives of our patients, providers, and community members, to really understand what are those drivers to extending access to some of these hard to reach populations, and what is the role that Central Health can play in that capacity. So as you might recall, this was the presentation that you received last week by our team that really did that drill down and gave you that detail. Today, what we're going through is the community health needs assessment, as Abhi had mentioned. So that thorough, detailed analysis of what are the health needs of our patients across Travis County. Where are some of those unique needs at that micro level? So when I say micro level, it's that neighborhood level to really understand locally what are some of the needs of the safety net population in one area versus another, to really help inform us on what our future looks like. So how do we position ourselves to really impact health and wellness for the safety net population across Travis County? Next week, we will be presenting to you the service delivery strategic plan. So what that entails is a comprehensive, high-functioning healthcare system strategic roadmap to guide Central Health to really impact health and wellness for the safety net population in Travis County. Next slide, please. What we've done on slide 4 is just provided a very detailed look at all of the work that's been done. And again, I know that you've seen this slide in the past, but really want to acknowledge all of the hard work and commitment of the Central Health team with this effort. So we have been working diligently with Central Health leadership each and every day to really get to where we have, to get us to where we are today. What that means is we've done a very detailed look at the health needs at those local levels, which we'll describe to you here shortly. We've identified gaps. So what are the gaps in our current system today? And what are the roles that Central Health can play to address those gaps? We facilitated a visioning session to really talk about and dialogue on what is it that we can achieve together, which brings us to where we are today to present these findings. Last week, as I had mentioned earlier, we did present the Voice of the Community work stream to the Board of Managers. We also conducted an in-person strategic visioning, we conducted an in-person strategic visioning session with the Strategic Planning Council in December, and then had a follow-up meeting with them last week to review with them our findings and work. That council represents leaders from Ascension Health, Community Care, Integral Care, Sendero, and UT Dell. Next slide, please. Over the next few slides, what I'm going to do is walk you through the high-level findings from the Community Health Needs Assessment. What we'll do is start from the very foundational elements of that, which is how we even looked at and defined the service planning and assessment regions. And then we'll walk through the outcomes and data that was concluded from this study. Next slide, please. On slide 6, what we've done is we've illustrated how we've divided Travis County specifically for Central Health. So when we look at Travis County, we have divided Travis County into 14 planning and assessment regions. And this was a tremendous work effort on behalf of the Central Health team as well as Guidehouse to really study at the census tract level what made sense for health planning purposes. So some of the factors that we evaluated included the geographic borders, the level of urbanization, transportation resources, and population density to develop these definitions. And really core to all of this is to understand at those local levels what the healthcare needs are for Travis County's low-income and underserved populations. Next slide, please. Slide 7 provides an overview of the population for those individuals with incomes less than 200% of the federal poverty level. So this slide is extremely important for 2 reasons. On the left, we've provided you with the absolute population with incomes less than 200% of the federal poverty level so that you can understand where these patients or residents reside across Travis County. The map to the right provides the population density, so density per square mile of those patients or residents with income levels less than 200% of the federal poverty level at the census tract level. So what's important to note is that when we think about population density and where most of these residents live, on a density basis, a large portion of those patients live along the I-35 corridor. Based on a further review of the I-35 corridor, that's also home to high density housing, as well as additional social determinants of health needs, which we'll get into a little bit later on in this presentation. Next slide, please. What we've done to summarize at a higher level is divided Travis County into 3 focus areas. We have West Travis County, East Travis County, and the I-35 corridor. When we think about the patients that Central Health serves through our MAP Basic, and sliding fee scale programs, approximately 67% of our enrollment today resides in the I-35 corridor. That area also represents nearly 3/4 of the county's population that have incomes less than 200% of the federal poverty level. Runberg represents at a micro level, the geographic area with that largest proportion of the population at 17% of the county's population with less than 200% of the federal poverty level. East Travis County represents the second largest region in terms of Central Health's enrollment. And they also represent the second largest region in terms of total population with income levels less than 200% of the federal poverty level. And that is followed by West Travis County, which represents about 8% of the total population with incomes less than 200% of the federal poverty level, and approximately 5% of Central Health's enrollment today. Next slide, please. So as we think about those geographies and the areas where we know our patients reside today and where they may reside in the future, it's important to note that we've evaluated this analysis based on 4 distinct areas. We've looked at demographic needs, health status needs, access to care needs, and social determinants of health needs. So when we think about access to care, it's physical location, provider access, and Central Health network. We know that our patients often have multiple chronic conditions, and there's also a need to help them navigate the system. As part of this analysis, we looked at care coordination and how are our care managers and care navigators helping our patients transition across our network. Additionally, we also heavily considered transportation as a factor to really understand are patients able to reach our services. When considering clinical services, do we have the appropriate scope of services to really meet the healthcare needs of our safety net patients? That includes primary care, specialty services, behavioral health, and street medicine. And when we think about clinical services, it's really important to acknowledge the relationship with access, because that's included across the continuum of care. So that includes hospital, ambulatory, and post-acute. When we think about community engagement in our enrollment, do our patients know how to navigate our network? And is there any education we can do to really enhance their experience so that it's a seamless experience? Is there additional outreach that's required so that we can expand our reach and really reach some of those vulnerable populations that we don't touch today? Okay. Next slide, please. Slide 10 provides a very high-level summary of some of the detailed slides that will follow. But at a very high level, what we've done is summarized our key findings for access to primary and preventative and specialty care across the continuum, management of chronic health conditions, behavioral health, and social determinants of health. So starting up at the left corner, top left corner, we're going to go through access to primary and preventative and specialty care across the continuum. Our detailed analyses found that Travis County's safety net population is vastly underserved and experiences great challenges trying to access healthcare services across the continuum. We know that large shortages of physicians exist across the county, so county-wide, payer agnostic, and that it's often difficult for safety net patients to access care on a timely basis. We know that they often use the emergency department as a source of care, often on an emergent or episodic basis, and that opportunities exist to really position ourselves so that these patients are receiving the right care in the right location at the right time and to improve health and wellness for these patients. Some specific examples include the fact that Central Health patients in total have screening rates that are far below the Healthy People 2030 program targets. Additionally, patients residing in East Travis County, as well as along the I-35 corridor, have less opportunities because of the density of need for primary prevention services. So it's important to align our services and access points to overall demand as we think about the future. Moving to the top right corner under management of chronic health conditions, Central Health patients have higher rates of chronic disease and delayed receipt of critical healthcare services that are needed to manage those conditions. So opportunities exist to really improve the population health and chronic disease management for these patients through advanced care models. An example for this specific area includes patients who reside along the I-35 corridor who had the highest rates of chronic conditions. Moving to the far left bottom under behavioral health, we know that many factors leading to mental health episodes and substance abuse disproportionately impact patients served by Central Health. We also know that stigma related to behavioral health in a highly minority community affects patients' willingness to seek help and receive care. On a very micro level, West Travis County had higher prevalence rates of behavioral health issues and substance abuse when compared to county averages. When we look at social determinants of health, we know that racial and ethnic minority populations are more likely to be socially vulnerable due to their increased likelihood of having incomes below the federal poverty level. This also increases the probability that they could live in substandard housing and have low access to healthcare providers and services. For example, regions where 50% or more of the population is Hispanic, specifically Del Valley, Dove Springs, Colony Park, Hornsby Bend, and Riverside Montopolis, face greater social determinant challenges in comparison to other regions. Next slide, please. On slide 11, what we've done is a very detailed analysis to evaluate from a county-wide perspective the physician supply. So this is payer agnostic, really trying to understand what does access look like for any patient in Travis County, regardless of their health insurance type. And what we found is that by and large, shortages exist across almost all specialties for physicians. And these shortages are projected to grow over the next 5 years. Specialties where shortages have been projected to exist greater than 50 physician FTEs include primary care, cardiology, gynecology surgery, ophthalmology, and radiology. Why this is so important for Central Health is because it impairs our ability to recruit providers to sufficiently serve our safety nets healthcare needs through a contracting structure. And we know that these countywide shortages are expected to grow and will further exacerbate delays in care for our safety net patients. It also makes it difficult to hire physicians that represent the unique diversity of our patients that we serve today, so that we can assure that they're receiving care in their language of preference and their cultural lens. Next slide, please. On slide 12, what we've done is a very detailed analysis of Central Health's current physician complement, which is not sufficient to meet the estimated needs of our enrolled population today. So what we've done along the left column is listed the specialties for primary care and medical. Surgical is provided on the following slide. And then along the middle column is provided an estimate of the physicians that are dedicated to treating Central Health patients exclusively today. The far right column represents the physician need, so the number of physician full-time equivalents that are appropriate and needed to serve Central Health's patients. And as you can see, there are shortages across all specialties. Next slide, please. Slide 13 represents the surgical specialties. And you can see that almost 35 surgical physician FTEs are needed to support our currently enrolled patients today. Okay, next slide, please. When we think about provider shortages, it will be no surprise when we look at chronic condition outcomes for Central Health patients specifically. So on slide 14, what we've done is summarized Central Health patients' chronic conditions at the micro level, so for across each of the service planning and assessment regions. And what you can see here is that where the box is shaded is that our Central Health patients have a higher prevalence of a chronic disease when we compare to our own Central Health county average. So when we look at this analysis, we can see that areas such as Garrison Park, South Congress, East Central Austin, as well as pockets in Jonestown, Anderson Mill, in Oak Hill and Hudson Bend, have opportunities to expand access and improve outcomes for some of these chronic conditions. That is followed by other pockets of opportunity on a smaller scale in these other areas. What we know is that there is a need for more comprehensive, multidisciplinary healthcare, treatment planning, and care coordination to really help coordinate care for these patients, navigate a system so that they're receiving the care that they need and accessing those services at the right time. Some of our current challenges today are further compounded by the fact that there is not a shared electronic medical record or widely accepted health information exchange to tie providers together. So as patients often seek care at different locations due to their ability to receive a timely appointment, or perhaps it's closer to their place of employment. There's not a way for providers to really, contribute to that continuity of care because they don't have the patient history. And there's really a need to tie that together to assure seamless transitions in care. Next slide, please. When we look at factors that impact mental health and distress, as well as substance abuse, we know that patients served by Central Health are disproportionately impacted. And at a micro level, areas such as Garrison Park, South Congress, East Central Austin, downtown, West Central Austin, South Central Austin, Jonestown, Anderson Mill, and Oak Hill and Hudson Bend have higher needs for behavioral health and substance abuse when compared to other neighborhoods within the Travis County planning region. We know that Central Health patients are disproportionately impacted by inequity, low income, poor physical health, unemployment, and high cost of living, and these all contribute to mental distress and substance abuse. Next slide, please. From a social determinants of health perspective, we know that access to healthy foods and digital tools such as the internet are critical to really connect with patients and maintain positive health outcomes. From an access to healthy food perspective, 25% of the residents in Colony Park and Hornsby Bend are both low income and have low access to food. Greater than 50% of the residents in Dove Springs, Wells Branch, Tech Ridge, Pflugerville, Colony Park, Hornsby Bend, and all of West Travis County live in food deserts. When we think about computer and internet access, which is so important when we think about our future strategy to connect with patients and engage them in their care, a quarter of the households in Riverside and Montopolis have no or slow internet, and double the number of households in Dove Springs, East Central Austin, and Rumburg have no computers when compared to Travis County overall. Next slide, please. I'm gonna hand the capabilities and gap analysis summary off to Dr. Sharma.
Thank you, Danielle. So as you have seen by now, there are significant gaps across the board. And when we think about the needs in the community, and then we overlay a physician deficit on top of that, the situation doesn't look well at all. So again, where we are right now is there are gaps with care delivery, and the lack of appropriate physician and supporting clinical resources poses a challenge to how we meet those gaps as we look to the future. Now, when we think about meeting these gaps, one of the things that we need to understand are the capabilities that we have at Central Health. And the next section is going to talk about the capabilities that we think are critical to an efficient safety net system. So we go to the next slide. All of us are pretty familiar with this slide. This slide actually is a graphic representation of the different components that make up a high-functioning safety net system. So to oversimplify this slide, what you see towards the periphery of the purple cog are the service areas that safety net system systems need to be good at. So think about population health, primary care, specialty care. Those are the things that systems need to be good at because that's where the need is for safety net populations. What you see at the center in the purple cog are the support services that are essentially the engine that keeps the outer cog going. So care coordination, backend support services, enrollment, data, IT, communication between providers, all of those things are as essential as the service components and the outer cog for this system to function efficiently. Now, on the next slide, we provide an overview of what the capabilities and gaps assessment focused on. So the capability assessment was specifically aimed at identifying how mature central health capabilities were compared to the capabilities of some of the high functioning systems that we have worked with in the past. And the clinical gap analysis was to identify the magnitude of current unmet needs for 8 distinct service areas, starting from primary care through to dental. Now, if you go to the next slide, it describes some of the core characteristics of high-performing hospital districts. Now, it is extremely important for us to understand what these are because the slide that comes after this will portray where central health capabilities are compared to those of high-performing hospital districts. So 9 out of 10 districts that we worked with, the capabilities that are specifically needed to deliver care to the safety net population fall in these 5 buckets. So right at the top, you have access and capacity. The high-performing systems have broad geographic coverage, and they also have a robust service complement with an appropriate mix of primary and specialty care to meet the needs of the community. Number 2, most of these systems have robust data and analytic infrastructure. Now, we think about data, I always think of data as the bloodstream of healthcare. So we need to make sure that for a healthcare system to function appropriately, patient data is moving from provider A to provider B in an efficient manner so that collective decision-making can happen and patients don't fall through the cracks. And the use of data transcends just benefiting the patient. Data can also be used for financial and operational decision-making, and some of the high-functioning hospital systems do that really well. The third core characteristic is the idea of a system of care. Now, when we think about how different health districts are constituted, most of the districts own only a very small subset of providers. They depend on partners and affiliates to provide care for patients that are not being met by the providers that the system owns. Now, hence comes in the concept of a network or a system. We've seen that a lot of the safety net systems own providers, and then they have these optimized, accountable, and transparent agreements with other systems that allow them to hold systems accountable for the care that these systems are supposed to deliver to the safety net population. Number 4 is care coordination. So because of this idea and structure that is based on a system of care, it's extremely important that patients are moved from point A to point B in an efficient and collaborative manner. We've seen a lot of patients fall through the cracks, and this issue is more prevalent in the low-income population. And the importance of care coordination, again, cannot be underscored because we need to make sure that a patient is receiving care throughout the continuum of care versus just piecemeal, to make sure that they not only get better, but they remain better and stay out of the system, which again, has a lot of positive downstream effects for the patient as well as for the system. And the 5th thing that we assessed was member engagement. Now, member engagement is extremely important for safety. populations because of two reasons. The first one is low-income populations are often reticent about seeking care in the system. And until we go to them and tell them what the value of seeking care is and that there is no harm in accessing the system, most of the people in this population try to stay away from the system until it gets to a point where they end up in the ED, which drains system resources even more. And then the second reason is the linguistic and social nuances that exist within the low-income population, especially in Texas. So we need to be culturally competent not only with the way we engage our patients, but also with how physicians and people involved in active care delivery are trained. They have to be trained in delivering culturally competent care so that the idea of member engagement can be emulated in practice. So again, the 5 core characteristics of hospital districts include broad geographic access, robust data and analytic platforms, an efficient and optimized system of care, active care coordination, and active and personalized member engagement. Now, if you go to the next slide, it is a comparison between where central health is and where some of the systems are compared to central health. Now, the systems that we used here were ones that we worked with. So most of the systems are based in Texas, but there were some based in other states in the country as well. Now, I want to make sure that everybody understands the core differences between central health and some of these high efficient, high functioning systems. Now, because I'm in Houston and Houston is in Texas, I want to give the example of the Harris Health system. Now, there are 3 fundamental differences between Harris Health and Central Health. And these differences enable Harris Health to be on the right side of each of these scales. Those 3 differences are, number 1, Central Health is relatively new. When you think about Harris Health, it was established in 1966. So they've had a longer runway to get where they are. Number 2 is structure. They own primary care physicians, they own a hospital, we do not. And they drive a lot of efficiencies through owning providers in the market. And number 3, the basic function of Harris Health is extremely focused. They only focus on the population that is below 150% of the federal poverty limit. And they are extremely focused in the services that they are delivering to these patients. If you think about ourselves, our scope and scale is different. So I want to make sure that we understand that, because what this slide here shows is the green circle being the maturity of central health capability and the blue circle being the maturity of the best safety net systems in the country. And as you can see, across the board, the green is to the left of the blue. And again, these 3 fundamental differences are the key factors that are driving the deficit between where we are and where the other systems are. So we talk about access and capacity. Yes, we have broad geographic access, but that access is not being used optimally. If you think about data and analytics, we have a good foundational analytic backbone that can be used to inform clinical and strategic decision-making, but we don't have sophisticated forward-looking data capabilities that would allow us to refine our processes and meet the evolving needs of the community. System of care, we are hands down over-reliant on partners for some of our inpatient and specialty care needs. If you think about care coordination is limited because of 2 primary reasons. The first one is data sharing between systems is not appropriate and timely. And 2, staff is not being incentivized to coordinate care for patients. And we think about member engagement, we've seen a lot of positive moves in the recent past, But there's still a long way for us to go when we think about creating foundational processes that are proactively designed at identifying what a population, a community, a person needs, and then designing programs that are tailored to meet those individual needs. Next slide, please. So the first thing that we talked about was access and capacity, and then in the subsequent slide, we go into the details of this domain. Can we move to the next slide, please? Perfect. So the way to look at this slide is the numbers in the cells are indicative of the physical location of facilities in the areas that are on the left column in this chart. So we know that we have a fairly large number of primary care facilities, but as we start moving from primary care to multi-specialty care, the number goes down. Again, this just shows that the geographic expanse of our facilities is not where it should be, but it's not bad. We have facilities located in regions where patients reside, and those facilities can again be leveraged to make sure that access is made available. Now, the bullets at the bottom call out some of the key findings from our analyses of where these facilities are. So the overall capacity, as I mentioned when I was talking to access for primary care and walk-in care, is insufficient, which is primarily driven by the lack of adequate physician FTEs, but is also compounded by the distribution of primary care facilities, which does not align with where some of our high-need populations are. Now, for primary and specialty care, again, there is a deficit in both the physicians as well as in locations. If you think about post-acute care services, there are significant gaps, and oftentimes patients, once they are discharged from a hospital or from an ED, they just fall through the cracks and they go out of the system only to present an ED 5 months, 5 weeks later, which again compounds not only the acuity of the illness, but also puts additional burden on the system. Can we put the next slide, please? So the data in the chart is the same, but it is for East and West Travis County. And the stark difference that you might have realized is the numbers here are really low. And if you think about multi-specialty, the number there is a 0. And if you think about mental health, the number there is 1 for East Travis County and a 0 for West Travis County. And this underscores the point that the geographic location of these facilities is not adequate to meet the needs of the community, and we need to think strategically about how we meet this need of facilities being located at the right place. Next slide, please. So we talked about inpatient care and specialty care, and what this slide highlights is the location of facilities, hospitals, where inpatient and specialty care is available. Now, we know that Austin is a concentrated market. 85% of inpatient discharges come from 2 systems, and we are heavily reliant on one of those systems. Now, we also know that St. David's is used as a backup by a lot of our patients, so patients are reticent and they don't want to seek care. But when they do need care, the need is so acute that the only option they have is to go to the ED. And oftentimes, these patients go to the St. David's ED, not to mention that they also seek care at other EDs, but St. David's again came out as almost a last resort for emergent care needs for patients in our community. Next slide, please. So we'll go through data and analytics infrastructure next. Now, if you go to the next slide, it talks about how we visualize data capabilities at an organizational level. Now, the simplest way to look at this is to look at the green dots that are planted on the gray arrow in the middle. Now, if we move from the origin of this axis to the apex of this arrow, the maturity of IT and data capabilities is increasing. It's becoming more refined. Now, we also see the Central Health logo near 3. Now, what does that mean? Well, what that means is that we have the foundational capabilities that are sufficient for us to do business. But if we think about systems that are truly competitive in the market, there is room for improvement. Again, the best example here would be Ascension. I've done work with Ascension on the population health program, and they have advanced analytic capabilities that are employed to risk stratify patients and then to provide tailored care plans to these patients so that these patients are really seen by the system as a whole versus just being interactive and one case by case in nature. Now, the question then would be, okay, what is differentiating and what is transformative? And are those points that we should aim for? Well, the answer there is yes, right? So differentiating here, think about Kaiser. Kaiser has a broad network, and they get a lot of data from participating providers, and they use that information to not only care for low-income patients, but also to drive outcomes. If you think about per 1,000 outcomes for a system, Kaiser is right up there, and they deliver a lot of care to people who don't have insurance. And again, that's something that we need to learn from. If you think about transformative, this is where the payers are. So if you think about Aetna, Humana, they are really transformative because their whole business model is based on leveraging data to inform strategies and to make sure that providers are kept in check when it comes to utilization of services. All in all, this says that, yes, we have the foundational infrastructure, but we have room to improve. And the next step up for us would be to be competitive in the market so that we can use data to meet the needs of the community and to become more efficient as an organization. Now, the question in your mind would be, okay, why are we here? Why are we not above 3? So if you go to the next slide, it talks about what were the 4 key domains that we looked at that informed our decision. The first thing that we looked at was access to data. Limited interoperability is a core issue. So interoperability essentially is the ability for systems that are on different EHRs to share data with one another. Now we know that that is limited, and that's limited across a lot of the sophisticated providers as well. But what complicates this further is that even when we have agreements with provider systems around data sharing, we're not receiving data on time. And the data that we get is not enough for us to make decisions. So access to data across the system, again, is limited. Now, the second thing that we looked at was data infrastructure. From our point of view, it is adequate. We have the platforms, we have the systems to do what we are supposed to. Personnel and expertise, those are adequate as well. But if we look into the future, and the future being based on this idea of value-based payments, there is a conversation to be had around refining our IT capabilities to make sure that we are positioned to succeed in that environment. Data governance is limited. Now we know that we have contracts, as I mentioned. We know that those contracts include data reporting terms and parameters, but partners are not giving us the data that we want, and that data is often delayed. So a data governance model is something that we need to think about, but because right now that is not centralized, and some of the data governance and data sharing issues are a manifestation of decentralized data governance across the system. Next slide, please. So we keep talking about network of providers. and the service complement. But the idea that helps us execute on these ideas is the idea of the system of care. So the system inherently is based on the idea of partnership, is based on the idea of enabling partners to function at the top of their capabilities and sharing workload in a way that makes the system more efficient than the sum of its parts. So if we go to the next slide, it talks about what our network is. And we wanted to keep this simple. So we plotted our partners and our contracted providers on this graph. Now, the vertical axis of this graph is indicative of the number of patients that are seeking care at our partner sites or with our providers. The horizontal axis is the comprehensiveness of services that are available at these sites. Now, if you think about comprehensiveness, it is the number of services and the type of services that are being provided here. So what will stick out to you is that community care and Ascension are in the top right corner. What this means is these systems have a vast and diverse service complement, and our patients are seeking an inordinate amount of care at these two systems. If we look at the flip side, it also means that we are overly dependent on these systems. And when we think about future strategy, we need to make sure that the other systems and providers that fall in the other quadrants on this slide are being used in a way that is optimal and that allows us to make sure that access is not depending on whether somebody wants to play well with us. It is dependent on how the system as a whole is leveraging the capacity of individual constituents to create access and allow patients to seek care at their sites. Next slide, please. So we also looked at care coordination. Now, for a safety net population, care coordination and member engagement are extremely important. So when we think about care coordination, we go to the next slide, we specifically looked at, again, 4 key capabilities that form the foundation of care coordination processes. The first one was patient data. I think we've established that accessing patient data in a timely manner is a key deficiency that needs to be addressed. The second thing was provider communication. So for a patient to go from point A to point B, providers who are manning point A need to talk to providers who are manning point B, and they need to agree on a care plan, and the medical documentation for the patient needs to be moved from point A to point B. Now, what we saw was the provider communication across providers in the network is on a case-by-case basis. Now, the question here would be, why is that so? Well, if we look at the systems and platforms that are used for care coordination, we don't have a standard communication system. And I'm not talking about interoperability. I'm just talking about a secure portal for providers in the network to talk to one another. That is, again, a prerequisite for care coordination. And because we don't have platforms and systems that enable care coordination, provider communication is, again, on a case-to-case basis. Personnel is, again, another area that we looked at. So when we think about personnel, it's 2 things. The first one is, do we have the people? And the second one is, do they know what they have to do? Now, yes, we have care managers. Yes, we have care navigators. And yes, they know what they need to do, but there's a number mismatch. We don't have enough of care managers, care navigators to manage the population that we are responsible for. And the lack of shared incentives across different provider systems poses another challenge, right? So some providers might be incentivized to discharge patients quickly because their reimbursement is tied to length of stay. Others might be focused on making sure that the patient only leaves the system when they are well. So these disparities and dichotomies around incentive design is again a key issue that needs to be addressed when we think about refining care coordination across the system. Now, the next slide talks about some of the accomplishments and the magnitude of care coordination activities that we've engaged in the recent past. So if you go to the next slide, it talks about the medical management leadership and how that brings the components of different parts of the care continuum together, and this has yielded some results that have to be called out, right? So the scale of the care coordination operations right now is good. A significant number of outpatient follow-up appointments have been scheduled, 9,000 patients who are at the higher levels of acuity are being engaged post transitions of care. And again, the way we are using our care coordination resources is extremely efficient, but just the lack of enough care coordination resources and the lack of a communication platform are the two key issues that need to be addressed as we look into the future. Now, if we move to the next slide, it talks about member engagement. Now, as I mentioned, tailored and culturally competent member engagement is the linchpin of success, because until you get people into the system, they're not going to get care. And the way we need to think about member engagement, if we go to the next slide, is through the step-by-step process where we are focusing on capabilities for 4 key steps in the member engagement process. Now, the first one is identifying and stratifying. We need to make sure that we have enough data on our population that allows us to stratify patients, not only based on clinical criteria, but also based on cultural and social criteria, so that we can target them with extremely tailored and culturally competent messaging campaigns. And that would then allow us to do number 2, which is connect and serve. Now, once we've identified individuals, we need to make sure that they are integrated into the system and that we are aptly and appropriately delivering care and services to our population. Now, once we've done that, we need to make sure that we inform patients about the services that they can seek within the system and that we actively follow up with them. And this is where I think our approach for the safety net population differs from our approach for the commercial population. For a safety net population, engagement and follow-up is extremely critical. Now, if we do 1, 2, and 3 effectively, what that would allow us to do would be to retain more people in the system and then to expand the scale and scope of our services by making sure more individuals are joining our system. Now, we know that enrollment has been expanding, and we also know that there are some inherent detractors that keep people away from using these services. Now, one of the things that we've highlighted here is that MAP can be confusing, right? So what services can I get? Where do I go for those services? The whole idea of having coverage and using it is, again, something that is critical for us to understand so that we can not just enroll people, but also make sure that the enrolled individuals are seeking care that they are eligible for. Can we go to the next slide? Okay, so where we are right now is we started with what the need in the community is, the fact that the physician complement for central health is deficient. Then we talked about some of the capabilities that we need to focus on, or capabilities that we can leverage to meet those needs. And in this section, I will talk about some key gaps in care delivery. So if you go to the next slide, it provides the summary of our assessment of gaps in care. Now, the way we ran this analysis was at the level of a service area. So we defined 8 service areas that we then analyzed to identify these gaps. So you can read 1 through 8. These are the 8 service areas that we specifically targeted. Now, I want to remind everybody that the way we've categorized these gaps is based on unmet needs. A service area where only 50% or less of the need is being met is a significant gap. A service area where 50 to 70% of needs are being met is a moderate gap. And if we are meeting more than 70% of service areas needs, then that gap is minimal. Now, what's striking on this slide is that specialty care, hospital care, post-acute care, and dental care present significant gaps. And what this means is, as an example for specialty care, our physician complement right now is sufficient at its best to meet 37% of community needs. Now, I also want to make sure we talk about primary care here, because although the gap here is moderate, but it's borderline moderate. We are only meeting 55 to 60% of primary care needs. Now, if you think about the volume of patients that are seeking care at primary care clinics versus specialty care clinics, it's way higher for primary care clinics. Now, what it essentially means is we cannot prioritize areas based on just the magnitude of the gap alone. We also need to think about the population that is being benefited through the closure of these gaps when you think about where we focus our attention into the future. Now, in the subsequent slides, I'll go one by one through each of these areas. So if we go to the next slide, it talks about primary care. So for primary care, as I mentioned, the gap is moderate. Now, one of the things that we have identified is that, yes, we have locations, but the locations for primary care are not appropriately located. Yes, we have physicians, but the physician complement is not enough. Now, what these two things collectively indicate is that the gap for primary care, given the number of patients that seek primary care, needs to be addressed, and that has to be an area of priority for us as we look into the future. The second area we looked at was wellness and prevention. We want to make people healthy, and we want to keep people out of the system by virtue of them being healthy. Now, the underpinning there is focus on wellness and prevention. So the gap here was, again, moderate. But the thing that I want to highlight here is that a lot of these services are being delivered in primary care clinics. And again, it's, to me, if we sum the volumes for wellness and prevention related needs and primary care needs together, this is a significant area that we need to focus on. Although the gaps per se are moderate, but again, the volume and the overall scale of this need pushes this to, again, the top 3 or 5 things on a priority list. Number 3 was urgent and convenient care. So right now we have 8 locations, but when we think about whether these locations are being utilized and what the need for urgent and convenient care is, there is need, but the need is not significant. Yes, people prefer same-day appointments, but if we were to focus on access, primary care would obviously be something that we focus on first before we look at urgent or convenient care. Not to say that these are not important, but the linear nature of care, again, dictates that we think about the top of the funnel first, and primary care, because of the scale of need, is the top of the funnel, which needs to be addressed. Next slide, please. So for specialty care, the gap is significant. As I mentioned, the overall scale of needs that are being met is in the 35 to 40% range. But if we take a deeper dive and look at the need at a specialty level, some of these specialties, we're only meeting like 7 or 5% of community needs for some of these specialties. Now, we know that we are dependent on community care and extension for a lot of these services. We have contracts with them. So as we think about the future, we need to really think about what the role of specialists is in our community And how can we make sure that we not only optimize the use of our agreements with Ascension, but also how we develop a network of providers that meet specialty care needs in the community. And like I mentioned, for some of these specialties, it was really striking. The unmet need is 83, 93%, which is huge. And essentially means that for those specialties, there's zero access. Number 5 was behavioral health. Danielle talked about behavioral health. So integral care provides a lot of these services, and they have nice facilities. But if you think about where these facilities are located, there is deficiency of these locations in East and West Travis County. And again, that compounds the scale of these deficiencies. And if you think about COVID and how mental health issues have come to the forefront, with the number of diagnoses per 100 patients going up by 70%, the need for behavioral health for this community is even more, because again, low income and lack to some of the social needs aggravates mental agony, and the need for behavioral health service again is substantive in our populations. Dental. So current access to primary and specialty dental services is not enough for us to meet the need. And we need to be extremely strategic about how we meet these needs. Yes, these needs are capital intensive, but we don't have to buy a dental chair. We don't have to directly invest in the capital that is required for these services. We can partner with other organizations. So again, although these are capital intensive services, just because they're capital intensive does not mean that these should be pushed to the bottom of a priority list, but because there are significant gaps, they should be higher up in the priority list as we look to future strategies. Next slide, please. So number 7 was hospital and inpatient care. So we know that Ascension provides a lot of these services, and we've seen instances where it's next to impossible for our patients to get a bed or get an appointment for a surgical procedure. Now, we ran the numbers here, and based on the population that is enrolled, 30 ED stations and 130 inpatient beds are required to meet what we are targeting for our enrollment efforts, which is individuals under the 200% federal poverty limit. Now, that is a big, big task. Think about opening ED stations or running ED stations in partnerships with others, or just getting into contracts with individuals or systems that provide ED care. It is a big ask. And when you layer 130 inpatient beds on top of that, it's essentially setting up a hospital with a very robust ED department. So again, a lot of things for us to focus on, but specialty care, especially in a hospital and an inpatient setting, is a key deficiency that needs to be addressed. And we're not saying that we go ahead and build a hospital right now, but we, again, need to think about how we get to a point where we might be looking at setting up a hospital, because, again, it has to be incremental. We need to think extremely strategically about how we make sure that needs are being met this year, and how do we make sure that we develop a system that provides the foundation for us to meet the ever-increasing, ever-evolving needs of the population, especially for hospital and inpatient care. The last thing we looked at was post-acute care. Now, there is an overall lack of services for post-acute. Think about rehab, LTACs, SNFs, respite. This is, again, a key area that we need to focus on, because for patients who do get admitted to hospitals, what happens after they get discharged is not a good experience. They don't have appropriate handoffs, which makes sure that they are being handed over to a post-acute provider, and the dearth of post-acute providers and capabilities poses significant challenges to keeping patients healthy once they are discharged from an acute facility. Next slide, please. Okay, so that was, I know that was a lot, and I will open it up for questions and comments now.
Yes, thank you very much, Dr. Sharma. So do any of the board members have any questions at this time? Yes, Manager Valadez?
Dr. Sharma and Danielle, to your team, thank you all very much for confirming what many of us have seen time and time again and know exists in our current community and our past community. I just wanted to make sure that you all understood, you know, the city of Austin is a very racist community. And in 1928, they had a master plan that specifically segregated our communities. That's why you see east of 35 and west of 35 so significantly disparate in what they provide, because those attitudes and those leaders who had their children become leaders and administrators of the institutions that were providing services had that mentality, had that attitude. So I think this is proof positive that that continues to exist. It was, and I want to thank you for outlining so much information that at least confirmed using current data. I just want to know, where do you think, how quickly do we need to have the discussions about who's going to be providing the services? Are we going to be owning? Are we going to be first working with our enterprise members to see what it is that we can do to expand what they're doing in order to accommodate some of those immediate and interim needs as we move forward to perhaps buying a hospital or not? And another thing, I'd like to know whether or not we have now included integral care and Sendero and brought them to the table in the discussions of immediate, midterm, and long-term goals of accomplishing the closing of these huge disparity gaps.
Yes.
And then
Thank you,
and then
Thank you.
and then
Thank you,
what, just
Manager
one
Val.
last thing, to begin, just to, for my own edification, you know, we talked about in terms of this is 70, we're providing 70, 77, 71% of the system's services to the 200 FPL percent and lower. Where is the other, what is the other part? Is that going to be private insured, or, and you said in Travis County, it's not outside of Travis County, or is that private insurance and other things that are compromising that additional part? So
Thank
I
you,
have
Manager
other things,
Valadez.
but I'm going to let somebody else speak.
Yes, thank you. Dr. Sharma, would you like to respond
Yep.
to anything?
Absolutely.
Yes.
Yes. So to answer the first question, which was, how do we think about whether we own capabilities, manage capabilities? This exercise, Manager Valdez, is focused on the what we need to do. And what we'll end up with is a strategic plan that would list areas of priority. So based on where the needs are, based on our assets and resources, these are the 5 things. These are the 10 things that we need to do. So that's the what. We will, and Monica, please correct me if I'm wrong, we'll share it with the Board of Managers to get official approval. And after that would be the how we actually get it done. Because for us to think about how we need to do it or how we do it, there are other components that needs to be assessed. So allocation of capital, the distribution of needs in different pockets. What is the community expecting? What are the stakeholders ready to do? How does our relationship with Ascension, with community care, with other entities help us design the system of care and how we actually get that done? So to answer your question, at the end of this, we'll know the what, the how will come after we get approval for the what we need to do.
And just to
Thank you.
build on
Wait,
that,
wait. Manager Valadez, let's let, did you have another, were you just repeating a question? No, okay, well, let's let Manager Bell,
Actually,
ask his question.
Chair, Monica could address the second question.
Okay,
Those that are-
oh, sorry, yes.
Sorry about that. I just wanted to complete the answer to Manager Valadez's question. So absolutely, Integral Care, Ellen Richards and David Evans have been participating in our advisory council, and Mary Carol Jennings from Sendero Health Plans has been in the advisory council, and we've also invited Wes to participate as he's able with his busy schedule. And then the operational financial sustainability and implementation planning is the kind of phase 4 of this longer project, Manager Valadez, that you approved as a board as part of our budget resolution strategic priorities. Thank you.
Yes, so I'm going to take, is this a follow-up? Manager Valdez, do you want to follow something up with this, or shall we?
Close this conversation up, and I'll send you all information and questions that I can hopefully have responded to, instead of just saying, hey, man, I didn't get that, or we still silence. So I just wanted to know that at the completion of all of this, when it is brought to us, will the public, again, have any opportunity, thank you, Dr. Bell, to see this before we actually adopt a plan in case it needs to be tweaked? And the only reason I ask that is because I have been an advocate of whenever we have the decision makers or the treetop administrators making plans that need to be implemented for tweaking, they rarely, never, and mostly never include the patients or advocates as to maybe one or a couple of them to see what needs to be done. And that's my final comment for the moment.
Right, thank you, Major.
No, is that going to happen, Dr. Bell?
Okay, well, so yes, so Dr. Bell, your question, please.
Thank you, Manager Brinson, or Chair Brinson. Manager Valadez, I wanted to echo the fact that once we get this in a, what I think Dr. Sharma said is a strategic plan, all right, format, then that's when we can go out to the public at that point in time and get their comment on it. What I understood you to say at the board meeting was that the voice of the community information needed to be sort of sent out to the public. Well, that is the public telling us. The voice of the community was the public telling us where they thought the gaps were. All right? We have to take that information, we have to take the information we've received today, and then when it's all formulated as a strategic plan, that's when we can go out to the public. And then we'll go to the public again when we have our strategic priorities and we fund them. All right? Because we need to have input on where we put money. So I do think that the public will receive adequate information as we go forward.
Thank you, Manager Bell. And Manager Jones?
I think Manager Mustaita put her hand up first, so I'll defer to her and then I'll answer.
Okay. I'll go after her.
Well, she's saying she'll go after you.
Okay, well, first of all, I'd like to thank you all for the presentation. This was extremely helpful for a board member who's been here a little over 4 years now. But it does raise a lot of questions. And my point I want to raise is that I do not think that this is anywhere near adequate enough time for us as board members to sort of digest and analyze and discuss the implications of what you're saying. And so I would encourage that somehow, as we go through this process, Chair Brinson and also Chair Bell, that we allow our board members to have time to digest some of the information. I'll just emphasize just a couple of points. You talked about the changing demographics. These demographics are changing not only over a period of time, they're changing within 5, 6, 7 months. And so we're planning for something that is dynamic. And so we need a mechanism to, as board members, to talk about what the community looks like particularly. That was a point that was made. It was interesting to me. I didn't know. I know we had 200% of poverty and below as our catchment, as our target area, whereas Harris County, according to your information, has 150%. And so the question is, why are those dynamics in Travis County so much different than they are in Harris County? We also you talked a lot about the types of high rate, I forgot the word you used, but the top-notch hospital district, which it appears that Harris County might fall into those categories. We also should try to aspire to be a top-notch, not necessarily replicating what Harris County did, but certainly addressing those issues. And then finally, some question is where, I mean, here we are almost 20 some odd years since the formation of this district. Why are we so far behind in terms of addressing some of the challenges that we see here? If Austin is the premier city in Texas and Travis County is the county, why haven't we done this stuff before now? So I'm just saying these are examples of the types of things that I think that we need more time to digest and address among ourselves with the data that you provide so that we can make reasonable recommendations to go forward. One last thing is you mentioned a great deal about the void of health care providers in our community. We spend $35 million a year to support Dell Medical School. Why is that not an issue for us to address each time that budget comes up? So I'm just saying there's a lot of information we need to digest here before we can come up, I believe, with our reasonable strategic plan as we go forward. Thank you.
Thank you, Manager Jones. And now, Manager Musaita.
Yes, thank you. Thank you so much for that presentation, for all the information that you provided. I think this is not new information to us. I think we all have speculated this information, but I'm glad we have it more concrete data. Now, my hopes are, I know we can go back to the why, but I'm more about how can we find solutions to solve these problems, and what can be easy fixed, and what can within our control as Central Health. I understand there's a lot of issues that you propose, but I feel like I see Dr. Shelsa and Jonathan Morgan on here. I would hope that we start working on these issues that are easy fixes that we can in terms of preventative services like cancer screenings, as you've highlighted in your report, alongside addressing the other issues that may or not within our reach within a year or two, but these are perhaps issues that we can address. I know there's a lot of information that we, as a board members, we need to absorb, but I hope that we are also focusing on solutions, and rather than speculations of why things happen, things we have no control, let's control what we can control to move forward. Again, thank you, and I look forward to our next meeting. Thanks.
Thank you. Yes, Manager Jones?
Well, I would just like to respond briefly to what Manager Musaita said. I agree with her. We don't want to focus on the past, but part of the reason where we are here today is somebody didn't focus upon the past. So I think that we need to be mindful of what we've come from in order to go forth. But I'm not, the implication was not that that's all we need to spend our time on, but we need to be relevant, concerned about what has happened in the past.
Thank you. And Mr. Giesland?
Yes, thank you, Madam Chair. There might be some other questions related to this presentation that you've seen today that, Madam Chair, I need to yield to, but I would like to come back and, as best I can within the confines of the agenda, address some of the issues of the past and, quite frankly, take ownership of it.
I think that would be great. And I think it may be worth, we can vote on it, but it may be worth adding an additional meeting to of the Strategic Planning Council to hear some of these questions that Major Valadez had brought up, and to hear the answers and understand more thoroughly. Yes, Manager Motwani, sorry.
Thank you, Chair. And this, a comment and a quick question, this will honor, I think, some of the commentary around past context as an important lens for future trajectory, as well as some of the notions that Manager Jones, I think, very aptly brought up around the dynamic environment around which we're planning. I'm curious. Well, first of all, the presentation was brilliant, dense, multifaceted, and it's so great to see, of course, what everyone knows anecdotally distilled into brass tacks and facts. And it's also just so well laid out in a way that clearly opens up opportunities for operationalization. I'm really looking forward to the processes, as we move forward. That being said, I'm curious about the data, particularly the demographic population data as related to the 3 subsets of the county, and really otherwise. I'm wondering how much, especially given the context that Manager Jones referenced, is there any evaluation or assessment of previous demographic trends or socioeconomic trends and how they may have historically changed over time, maybe the last decade, for us to get a better, kind of view of where we're coming from, to see where we're headed, or, not only in sort of socioeconomic demographics, a la income and poverty and what have you, but also, is there perhaps an assessment of what population migration has looked like in our region, as well, so that we can get a better handle on not just the past, but also what that could mean for the trajectory. And even though we can't necessarily predict everything, I think it gives us value for some predictive analytics, but it also gives us an idea of how quickly things can change. And I'm wondering if some of this is informed by that. The reason I asked that question is because, and y'all will forgive me, and I know the medical professionals as well as the medical administrators in the room, well, at least I request that y'all forgive me about venturing into this territory that's way out of my league, but whether we are making sure to stay as focused as possible on on services that can be as modular as possible, or as, for lack of a better term within the industry, pop-up as possible, things that can be opened up and shut down quickly. Are we leveraging the technologies and the practices that enable, best treatment and best outcomes, while also leveraging the ability to be very nimble and dynamic, and maybe open up a shop and close a shop kind of thing, and open it somewhere else, to be able to be more reactive to what we know are going to be very dynamic populations? Long question, and maybe it can be answered offline too. So just wanted to make sure it got out there.
No, excellent question, Manager. And Dr. Sharma or Monica, do you want to respond?
I'm happy to
Danielle.
respond to that. Thank you.
Okay,
So
thank you.
I have 3 questions, but please correct me, but I'm going to kind of walk my way down, and if I missed a portion of it, but please feel free to, add it as needed. In regards to the data, so we did consider several data sources to get at the most current data at the most local level. So for example, the data looked at Central Health's actual patient data. So where do they live today and where do they work? So really looking at that in a holistic way to really understand what are the factors that influence their access points of choice. We also looked at the most recent census data, as well as the most recent CARES data that's published by the CDC. So several data sources were used to triangulate our findings in regards to the demographic analyses, but really driving very hard to get at that most granular level to understand what those local healthcare needs are. In regards to the migration across Travis County and, the relocation of certain, residents due to cost of living and the impact of large businesses as they come in and they're driving housing prices up or rental prices up. We did do a deep dive into that to really understand the impact of these businesses, such as Tesla, that are coming, building their presence, employing a large number of people, what's causing a large number of people to relocate to lower cost housing within the county. So that was heavily considered as we start thinking through how we position ourselves for the future and where we need to have access points to address their healthcare needs. So knowing that their healthcare needs are evolving based on where they relocate within the county. So absolutely heavily considered. Lastly, we absolutely agree with you in terms of how do we position ourselves to be flexible and adaptable as healthcare changes. So that is going to be part of the how, because we know that this patient population is like no other. So when we think about the safety net population and looking at just some of the social determinants of health that were presented today, there are going to be different vehicles that we need to consider as we reach these patients and improve their outcomes. So we really need to think through holistically on what is going to work. And it's not going to be one size fits all. It's going to be a multitude of solutions to really be their health partner. I'm going to pause there to see if that answered your questions.
Yeah, it's helpful.
Danielle,
I mean,
just to,
please.
sorry, just one of the, your point was extremely spot on, because one of the things that we discussed was a service line pilot. So we know specialty A is a deficiency. Can we test a pilot and see if that works? If it doesn't work, we can shut it down, but if it does, can we scale it out to make sure that needs for that particular specialty are met across the county? So again, we've had those discussions around these select pilots, which can, in your words, be pop-ups for us to test whether things work or not. Sorry to interrupt you, though.
Thank you, Dr. Sharma. Thank you as well, Danielle. That's helpful. You know, what I'm hearing is that we had point in time analysis for census demographic data and CARES data, and not necessarily an evaluation of over time. And I see Monica with her hand up. So from what I've heard up to now, before Monica, we had point in time. And then secondly, what I'm hearing is that, yes, obviously, or not obviously, but there's a certain consideration of the risk of maybe pigeonholing one area that is low in specialty if we were to install maybe those particular care types there. And if the demographics were to change within a year, then we would be well positioned to be able to reallocate those resources appropriately within the county. And that consideration seems to be prevalent, right? And so that's helpful to me. And I also just wanted to throw in demographically that when we're looking at poverty level as a metric, especially in a year when we're going to see historic inflation, you know, right now poverty level is 26K or so for a family of 4. And there's anachronistic ways of calculating it. Even if we're doing 200% of that, there's a high probability, I might guess, that a lot of families who are considered middle class, meaning 60K family of 4, are likely going to be hovering on this area because, you know, that's close to 200% of poverty. And so hovering in an area where expenses are high and where access to care may be necessary. And I think that there may be dramatic implications, at least on, again, demographic and socioeconomic shifts. So thank you. And Monica, please. Yeah, and I'm done after that. Thank you.
Yes.
Thanks, thanks, Chair Brunson. I just wanted to clarify, Manager Motwani, we actually did Guidehouse's analysis on the demographic report wasn't just the current point in time or looking forward. They did start with the previous 2 central health demographic reports. So we looked over time at those shifts in condition, in poverty, in density from the last 2 central health demographic reports. So I think it was the 2020 and then the 2017 or 2018 before that. And then after we are already starting, once we get through February, JP and Sarita and the team are going to start looking into this next year demographic report, building on the work that Guidehouse has done. So we're, you know, constantly revisiting the data to have the most up-to-date data, but building over time. And that was really where Guidehouse started.
Excellent, thank you. And Yes, Manager Jones, and then Manager Valadez.
Just quickly, I know that at APH, over these last 20 years, has been several community health assessment study that also incorporated epidemiological data. And so my question was, did you incorporate any of, or did you look at that, I should say, in terms of what your trends are over time at all, in terms of some of the data or recommendations that you put forth, or strategies you put forth for us to consider?
Danielle, yes.
Sure. So
Danielle?
yes. Oh. Okay. Yep. So we did consider trends over time. Also, a very important component of all of this work was the voice of the community work to really understand from the community's perspective what are some of the challenges or things that are even working well that they would really like to see us expand on so that they can really, receive the care that they need. So yes, absolutely, we did look at trends over time.
But my question was more towards the epidemiological. I mean, the mortality, morbidity, health outcomes of communities. Did we look at those trends over time?
Yeah, Abby, do you want to? Oh, you're muted.
Sorry. We did. One of the core outputs of our assessment was the distribution of the geographic distribution of disease states. So essentially, if we look at different regions within the county, where is the preponderance of the disease and how does that translate to other regions in the county? So yes, the basis for that was looking at epidemiological data to see what the scale of the disease states was.
Yes, Manager Musaita.
Jonathan Morgan has his hand.
Oh, Jonathan Morgan, I'm sorry. Mr. Morgan.
Thank you, Chair. I just wanted to clarify with Manager Jones's question that the APH Critical Indicators Report was one of the source documents that we provided the Guidehouse team as part of the analysis. It was one of multiple sources, and I think we're trying to really hone in on the epidemiologic changes for our patient population. So this under 200% Travis County residents. So there are certainly a lot of parallels to the APH Critical Health Indicators Report, but I think there are a lot of nuances that are specific to our subset of the overall Travis County population.
Yes. And
Dr. Rita.
Dr. Rita?
Rita.
Thank you.
Okay.
I just also wanted,
yes, thank you.
I just wanted to add, Manager Jones, that I've been in contact with Agent Stirrup over at APH, and they haven't published the new Critical Health Indicators Report yet. It's due out this year sometime. So the data that we do have is pretty old. So we're looking forward to that new report. I also want you to keep in mind that the report speaks to the population in its entirety, all of Travis County. So we're not really honing in and focusing on the population that we aim to serve, which are folks under at or below 200% of the federal poverty income level. So it's folks at all income levels, and sometimes that can dilute out, what you see in terms of prevalence in the different areas. And we can lose sight of populations that have needs and subpopulations with needs in certain areas when we look at the information that way.
Yes,
but we shouldn't assume that it doesn't give us indicators or trends of what's happening, because our populations are in and out of that 200% of poverty. So it should certainly be an indicator for us to utilize, to look at. Not solely, but certainly partially.
Yes, and Manager Musaita.
I just have one quick comment. I just want to clarify. By no means am I dismissing our history. That is never my intent, the past history, what happened in the past. And without really understanding what the past, we cannot move forward. But my goal is that we move towards solutions to provide the services that our community need and deserve yesterday, not now. So thank you.
Yes, thank you. Yes, and Manager Valdez?
Very much, Madam Chair. Okay. I just wanted to make sure that you all understood what I was asking for before. And what I had wanted at the last meeting was the data upon which the voice of the community recommendations was based. I wanted to know what the demographics was. I made a comment about we appear to be still missing Hispanic male representation appropriate to our demographic, but I was assuming that based on the breakdown of the Latino population and male, female in the household. And then I was immediately, I got a response, a comment by Mike, and then ultimately by Will, who said, oh, well, it was 18% Latino males that were part of the survey. And I said, well, I would like to see that demographic data. That's what I was referring to. I wanted to see the demographic data to make sure that it was appropriate to what we are doing here. And it was what the recommendations coming out of that was actually based on not a random sampling, but the accurate demographic data that our population is in Travis County at 200% minus FPL. And one more thing, I want to thank Shannon. I want to thank you and Amit for asking and stating the same things that I have asked for, a slowing down of the process, which I provided that in an email to Dr. Bell. And I'm glad they're listening to you. That I do want you to understand, Dr. Sharma and Danielle and everybody else that's working on this project. It is a worthwhile project. I want to thank Central Health for doing it, but I also want to make sure that we understand that there were no community needs assessments ever conducted by Community Care, to my recollection, until Jason got here. So we are already dealing with a gentrified demographic that has occurred as a result of the development and the ordinances and the laws and the failure to provide infrastructure that the city did not provide to our lower income east of 35 residents. Thank you for that. And I am very willing for us to improve this as quickly as possible. But I also just wanted to make sure that we understood that appropriate demographic data has got to be the basis of where all our recommendations come from. And I also wanted to know if John, the other John from the IT, had been involved, because he's the one I think that was handling the delivery system. He collects all the data from the hospitals and the providers. And I wanted to know if we were using his data, because I've had conversations with him in the past about these things, and the failure to interconnect, not use electronic apps or whatever, yes, so that we can speak to each other appropriately, yes, so that we can have a holistic view of a patient's medical treatment almost instantaneously. And I know that we've talked about that. And he said one of the problems we had is that all the institutions did not want to come together and agree on the same system. So that was part, yes, of the problem, the interconnectability. I was wondering if he was coming to the table.
Manager Valadez, thank you. Thank you, Manager Valadez. We are right now at about 2:58, and our goal was to be completed. Now, if anyone really wanted to, we could vote to see if anyone wanted to talk a little bit longer, or we can vote to have an extra meeting, another meeting, just among ourselves. And Mr. Burton wanted to make one comment.
Thank you, Chair Brinson. I just wanted to let Manager Valadez know that we are working on getting the information that she requested that will provide the entire board, the demographic information regarding our focus groups and our survey respondents, and that will be provided to the entire board.
What about the other John's participation?
I'm sorry, I didn't hear the question.
What about the other John's participation?
Yes, we used data. Yeah, absolutely. We used information from our data warehouse. John Clark has been part of our leadership committee from the very, very beginning. He's been fully integrated into this work.
I feel for you. Thank you very much.
You're welcome. And Manager Bell?
I just wanted to make a final comment, to address the timeline. When we first were previewing the presentation from Valley House, we were gonna have a 4 or 5 hour meeting. We decided that, the chair and I decided that we needed to break this up into bits so that people could actually understand what was in the data, have the robust discussion that we need. And so when we come down to trying to finalize this as a strategic plan, we have hopefully had enough time to discuss. Now, I want to reiterate that we have a meeting every week this month. And every week this month, we will spend time on this particular issue, no other issue. All right? So I'm telling you, we are taking time, all right? And I appreciate, and I think the chair appreciates all of the great discussion and the points that have been made. And we look forward to having that robust discussion in our future meetings.
Yes, thank you. Thank you very much, Dr. Bell. And so there was no motion necessary on number 1 and number 2. We need to confirm at the next meeting. So our next Central Health Strategic Committee meeting is tentatively scheduled for Wednesday, February 9th at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. So at this time, I am ready to accept a motion for adjournment. Manager Bell and Manager Valdez. Thank you very much, Manager Bell and Manager Valdez. And so thank you. That concludes our meeting.
Thank you. Y'all be careful tonight and for the next 5 nights. Below freezing degrees at night.